Hi, my name is Rahi Patel, and I'm a third-year medical student. And today I'll be discussing a meta-analysis of empiric antibiotic treatment for chlamydia and/or gonorrhea in United States emergency departments. Just for some background, in the United States, STI rates have been on the rise, and they've been on the rise in emergency departments as well. The CDC is recommending presumptive treatments of these infections, and the antibiotic resistance of chlamydia and gonorrhea has been increasing. Gender differences are prominent with these infections as females are often more frequently asymptomatic in presentations, but females may face more severe reproductive health outcomes, and these outcomes include issues with their pregnancy, fertility rates, and even include chronic pelvic pain. Our study objectives are to estimate the prevalence of antibiotic treatment rates for chlamydia and/or gonorrhea in relationship to the lab confirmation of these infections, and our objective is to assess gender differences in these estimates. For our methods, we did a meta-analysis of US emergency departments and looked at GC and CT testing and treatment between 2010 and 2021. These are the databases that we used to compile our articles. When we had our articles selected, we had 2 reviewers perform independent study selections, quality assessments, and data extractions. When there was a disagreement, these were resolved by a third party. The study quality was assessed using the JBI critical appraisal tool. And when we had data that had non-gender specific results, we classified this data as a combined sex category. And the random effects meta-analysis for pooled assessments of GC and treatment rates, GC and CT treatment rates. For our article process selection, we did a search, and that included 2,633 articles. Of those articles, 1,644 articles were considered after looking for duplications. And of those articles, 17 of them met inclusion criteria. These 17 articles represented 33,734 patients across the United States, primarily from the Midwestern United States. For our first set of results, we looked at positivity infection rates in the US EDs. The overall positivity was 13%. Of that, the female rate was 11% and the male rate was 23%. Our findings signified that female confirmed results were 2 times lower than the male counterparts of these results. When we looked at antibiotic treatment, the overall coverage in the ED was 44%. Of that, the female rate was 33% and the male rate was 71%. So our findings indicated that treatment rates among those who have tested were 2 times lower in females than with males. When we looked at potential overtreatment of ED patients without confirmed chlamydia and/or gonorrhea results, the overall rates were 44%. Of that, the female rate was 35% and the male rate was 64%. So our findings indicated that the potential overtreatment was 2 times higher in males than with females. For our last set of results, we looked at the potential undertreatment of ED patients with confirmed lab results. The overall rate was 40%. Of that, the female rate was 52% and the male rate was 13%. So these findings indicated that the potential undertreatment was 4 times higher in females than in males. In conclusion, we assessed the potential limitations. We looked at what was a true overtreatment or a potential true undertreatment. It's unknown if one is true or one is not. For example, when looking at the potential overtreatments, it's possible that these patients may have been positive in the ED, but it was too early in the testing window for the positive result to show up on testing. And when looking at the undertreatment, it's possible that a patient may have been positive in the ED and was sent home to wait for their test results. And in the meantime, when they got the results, they may have gone elsewhere for treatment or had come back to the hospital for treatment. But when we looked at this data, it wouldn't be included as ED treatment rates. Overall, 44% of those without GC or CT were treated, and 40% of those with GC or CT were not treated. So the presumptive treatment rates were 2 times lower in females than in males, but the potential undertreatment rate was 4 times higher in females than in males. So this overall shows that using symptoms to help diagnose STIs may miss infections, and missing these infections can have a disproportionate burden on women. Our results show that it's important for emergency departments to invest in a point-of-care STI testing method. Investing in this method may decrease the negative health implications of missing an STI diagnosis, and it can help with antibiotic usage, and preventing the overuse, which could lead to resistance. Thank you for listening. Does anyone have any questions?